So yeah, so the idea of this talk is based on ones I've done before, but generally one of the Leicester Royal final year registrars has asked for some more stuff about research, about the types of research and how we interpret it. But obviously they're not on, but so the rest of you will get to benefit from whatever it is I'm trying to say. So I'm the lead for research at LRI. Hakeem's the lead for research at the Glenfield. And I seem to have developed a slightly unhealthy obsession with things like statistics. So I'm not going to really talk a lot about stats. There will be a little bit, but mainly just about a slightly broad overview of research. And for those of you who've done some postgraduate research, certainly my MD was like this. The quote is about spending 6 hours reading 35 papers, so you can only write one sentence containing 2 references, and that's pretty much true. So what's this talk all about? So what I was going to try and cover in this brief conversation was, what are the types of study and research available in biomedical sciences? How one might appraise research. Everyone always asks, how do you read a paper? How do you appraise a paper? So I'm going to really give a quick overview of that. A little bit about stats and the problems that we see in published data, and let's say problems with data and science generally. So what are the types of research? Well, there's 2 types of research broadly, primary and secondary. Primary research is the data collection. Secondary research is the analysis of other people's data, essentially. And within primary research, you have these sort of 3 domains. You have basic sciences, which I've spent too many years doing at one point in my life. Clinical research, which is what we're we most frequently encounter, certainly UHL, mainly in the form of the NIHR trials. That is multi-center research trials that we recruit to. And also research is the epidemiological research, which is essentially looking at how populations change and how disease and population change, which we became quite familiar with during the COVID pandemic. So just going into a little bit more detail, first of all, looking at clinical studies. So within the clinical studies group, there are kind of 2 broad types of research: interventional research, which is what we're probably most familiar with, and observational research, which we are familiar with, but we don't necessarily recognize it as observational. And I come a bit onto the main differences between them. But if you're thinking of interventional trials, well, at the moment, certainly the Royal, we're recruiting to these studies, EVIS, March, T4P, and Mosaic, all of which are interventions, which are protocolized with varying degrees of blinding, and they're designed to look at whether an intervention is better than an alternative in a prospective way. Observational studies, you should all be familiar with the NAP4, NAP5, all the napping projects published by the college. And the fundamental difference here is that there is no prescribed intervention by a researcher. It's more looking at groups of data or looking at groups of subjects and observing what happens to them. There's also the ICNARC data sets, which again, form of audit, has been used in observational studies as well, looking at, again, COVID, but also looking at other diseases within the intensive care population. And within observational, you get the kind of case studies. Surgeons used to love publishing case studies. I've done 1 million heart valves and my outcomes are amazing, that sort of thing, that sort of case studies and case series. So this really gives an example, really just trying to give an example of what the trials are, which I've sort of gone through. So the basic sciences ones, anything in the lab really is basic sciences. So animal studies, for example. So these can be things that are development of protocols. They can be things that are actually looking at drug use in animals. They can be any kind of study which basically takes volunteers and healthy volunteers and looks at mechanisms of drug or injury. mechanism of disease, or taking out blood cells and looking at it down a microscope, which you make fluoresce. That's something I spent too long doing, that sort of thing. So, for example, the sequel ligation model of sepsis, that's one that's used. So if you're researching sepsis and you've got a drug that you think will work in sepsis, one of the first things you'll do is take an animal model, you'll make it septic, and one way is by basically tying off their bowel and sticking a needle in it. That causes peritonitis and causes peritoneal sepsis, and then you can look at whether your intervention or your observation, if you're looking at things like blood markers, are changed depending on the degree of sepsis. There is a whole talk about the problems with animal studies, not just the ethics, but also whether the data they produce is actually of any use. And it is an argument, and it's partly why we're seeing less, and many reasons why there's less animal research, but certainly within ICU type studies, it's actually becoming quite clear there's actually a very narrow range of animal studies that are actually useful in terms of models of disease. They are useful looking at safety of drugs. So if you give a rat a drug and it dies instantly, you might suggest it may not be healthy in humans. But looking at mechanisms, there's actually distinct differences, particularly in sepsis, between animals and humans, which has been the cause of many a failed trial. So looking at the clinical arm, so the interventional trials were the most classic, the one everyone goes on about as the gold standard, is the randomized controlled trial. I mean, this can also include non-randomized, non-controlled trials, which also count as interventional trials. But the gold standard is the double-blinded randomized controlled trial. So, for example, ECMO versus conventional ventilation, when that was done at Glenfield, that's one of the that's a very classic example of an interventional trial. Observational trials include things like taking blood tests from humans in ICU and looking at whether they express in various interleukins. They're trials where you're not actually giving a drug, or you're not really intervening in their care. The care has been led and directed by clinicians. Your role is really as an impartial observer, looking at what's happening. Oh, another roll over. But also things like diagnostic assessments. So again, during COVID, we all became very familiar with sensitivity and specificity when looking at COVID tests, and had long, boring arguments about whether they're accurate or not. But that's a form of observational trial. So when you're comparing a diagnostic test against a gold standard, such as echo or pulse contour analysis versus pulmonary artery catheters, this of course assumes your gold standard is gold. One could argue PACs aren't golden, but anyway, that's again another conversation for another day. And then the other group is actually we read and involved in quite a lot of these, the epidemiological type studies, and they involve various words with various meanings. Cohort studies, where you look at two groups of people. Let's say it's classic with smokers. I think it looked at doctors who have smoked and looked at their outcomes. We took one group of doctors who smoked. You look back in time and you looked at the one. Sorry, it can be prospective, can be retrospective. But you take one group who smoke, one group who don't, and you see what happens. There's a lot of overlap between clinical observational trials and epidemiological, particularly around things like cohort studies. And I'm not sure it's entirely important, but it just gives you, they do often fit into both categories. And the rest you can really read. But essentially, it's coming down to there are types of studies where we intervene, the types of studies where we observe individual test populations, which we can define, and ones where we essentially we either look back on them or look forward and follow what happens with patients. And the secondary research, which I'm not going to talk a lot about, that's essentially all the meta-analyses. And a new trend for this is the IPD. This is where you take data from published studies. You kind of beg the authors to send you the raw data, and you combine it with data from lots of other studies, and you do a big analysis on all of them and come up with a conclusion. So secondary research is essentially taking previously collected information in data and analyzing it. Okay, so they're the main types of studies. So 3 broad groups, and within those groups are lots of subgroups. But fundamentally, you're looking at your sciences, you're looking at clinical studies, and you're looking at your population studies. As I've mentioned, the main features that differentiate clinical trials are the interventional observational First of all, the big difference from a researcher's point of view, interventional needs a bucket load more ethics than consent. And especially in ICU where you're dealing with incapacitated patients who cannot consent. And remember, you cannot, for an adult, consent on behalf of someone, although you can in research. It's a bit, you can't for procedures, but you can actually in research. They call it consent, although really it's assent. Anyway, interventional trials, classically you have a control arm. You have, you have your placebo or one drug versus another drug. There's usually randomization. Occasionally there's blinding, which can be single or double blinded. So single blind is where the patient doesn't know what's happening. Double blind is where neither the patient nor the doctor know what the drug is or what the intervention is. And that's supposed to be kind of the gold standard. Sorry, and randomization is that patients are randomly allocated, and that has to be justified and how that randomization happens, but they're randomly allocated treatment or non-treatment or to one of the various groups. One of the most complicated randomizations, but also really interesting, was the big COVID study. What's it called? Looking at the various REMAP-CAP, I think it was, looking at various interventions in COVID. And they use something called Bayesian analysis, which I'm not talking about, but they use Bayesian statistics to randomize patients. And what that meant was that you had a computer. The way to model it in your head is that you had a computer that, instead of just randomizing an equal number to each intervention arm, it analyzed the data from each interventional arm. And if one arm looked better than the others, it prioritized future recruitments to the better arm. And the way the authors talk about it is that almost a bit like gambling, that the computer, it's obviously not one computer, but the computer and statisticians were deciding where the best bet was, where they should lay their money on the intervention that works. And it would randomize, not in a truly random fashion, but it would randomize patients dependent on where the best intervention appeared to be. And they'd keep monitoring the outcomes. And if it showed actually that's a false bet, then they'd start going on other ones. Or if it was a strong bet, they'd keep going on. And that's how they came out with interventions like hydrocortisone very, very early. Sorry, dexamethasone very, very early. The other thing about interventional trials are things like power analysis. So all interventional trials where you have groups and prospectively, you should power them. What that means is, do you have enough patients, and what is the primary outcome difference between the groups that you expect to see? And then you do some maths. If you want to do an interventional trial, there is the consort protocol policy, which, if you're interested, I've put a link on here. But essentially you can look it up, and it tells you what you need to do when you're planning and when you're reporting an interventional study. Observational trials need a little bit less, certainly in terms of ethics, because you're not actually involved in the treatment or care of the patient. You're not making a difference to the care of the patient. You're really looking at what happens when standard care is delivered in different ways. And yeah, I mean, that's essentially what it is, and I've talked a bit about that already. But it can be useful looking at comparisons between treatments or comparison between centers. It is often retrospective, but it can be done prospectively as well. Right, good. So the other thing that often comes up in exams, for those of you who have them, is different phases of trial and interventional trials. I found this really hard when I was doing my FRCA, but it's actually not really that difficult. The names can be a bit confusing, but essentially there are 5 phases if you want. There's a preclinical phase, that's the lab bit, that's the animals. And then I have what's called the is it safe? So that's where, I don't know if people remember Northwick Park, there was a number of people who developed very severe immune reactions. I think that was either phase 1 or phase 2 trial looking at immune stimulating drugs. And essentially phase 1 is where you give different doses of drug to patients and observe for reactions, to volunteers, and observe reactions, often healthy volunteers. And you're looking at what happens if you give a drug, what adverse reactions do you see in the immediate term? And that's basically to try and find a safe dose. The phase 2 trial is essentially saying, does this drug actually do anything? So your preclinical suggests it may be beneficial. Phase 2 is not a comparison trial. It's saying, I give this drug, is there any effect at all, or do they get worse? And you're still looking at your safety and how tolerable the drug is, but you're also looking for immediate and short-term what they put as efficacy. Phase 3, the trials we're all involved in at various stages in our careers, which is kind of is it better than the other drug or the placebo if there is no other drug? And that's where you get your big trials, and you get your randomized control double-blinded trials. It's all in phase 3, and we do a lot of those. And phase 4 is, right, you've done your trials, the drug works, MHRA, or on this slide, the FDA have approved it. It's been sold to people as the best thing ever, and you keep monitoring it. And it's kind of the post-market surveillance. And as we know, that is flawed, or can be flawed, particularly with things like OxyContin. But other drugs, the post-market surveillance it can be very flawed. But this is where the whole the black triangles, or what do the Americans have? Yellow label. Anyway, they've got different labels. So this is where you might see, when you fill it, I don't know if anyone's ever done it, but you fill in an alert for a drug because you've seen a side effect, or you've seen a patient deteriorate markedly with that drug. You fill in a form, send it to him at MHRA, or you do it online now. And that's all the phase 4 type stuff. So yeah, so they're the phases of trial. So you can either remember as numbers, or you can run it through the kind of is it safe, does it work, or is it better scheme, which is kind of how I remember it. So that is a very broad overview of the types of research that's done in intensive care and generally within biomedical sciences. And within these trials, you'll read, and I'll come on to this now when I talk about critical appraisal, you'll read various very, very long phrases, propensity score matching and various other words, which are designed to concisely explain some of the methodology, but actually it doesn't often really matter. What's important is when you look at a paper or read a paper, you just try and categorize where it fits into this scheme and into a scheme I'm going to come on to now. So critical appraisal. I essentially plagiarized this from the Centre of Evidence-Based Medicine, which is an Oxford group, which was around when I was a student, which was some years ago. And it's an attempt to try and make sense of the research that's published. I mean, there are millions of papers produced every year, and it's incredibly difficult to go through all of them. Well, it's impossible to go through all of them. But what critical appraisal is designed to do is take studies which seem to have had an impact and assess, internationally, and assess whether the impact is relevant to you and your practice. And if you have been asked for journal club, which is the commonest time any of us formally critically appraise a study, then these are kind of the 4 questions that if you can answer them, if the answer is no to any of them, you probably don't need to read the paper anymore. So the most important thing about research, and the thing I think is often missed, is what is the question? Is there a focused question? Is there a clear hypothesis? And when you're doing grant applications or doing ethics forms, that's one of the things that's really clear. You need to have a primary proper hypothesis. Sometimes you read trials and it's not really clear what it is they're doing or what they're actually testing, or what they claim they're doing isn't actually what they test in the statistical methods. So they'll say this is a hypothesis, but actually they test something completely different. But when you're reading a paper, I find it quite helpful to write down what is the actual hypothesis, what are they testing, and actually more importantly in some respects is what's the null hypothesis. So for those who don't know, and I will talk a little bit about it, frequent statistics is what everyone does at the moment, uses the concept of a null hypothesis and tests the null hypothesis. And what that means is the null hypothesis is that there is no difference. So salbutamol, let's say salbutamol improves outcomes in acute severe asthma. That's a hypothesis. The null hypothesis is, acute salbutamol does not improve outcome in asthma, and statistically say there is no difference in patients receiving salbutamol or acute severe asthma. So it's really important that whatever paper you read, you can make sense of what the hypothesis is. The second point is, are the methods valid, which is actually can be quite tricky, which is why what the background I gave earlier kind of helps you compartmentalize what kind of trial you're reading. But essentially saying, have they done the right thing? Have they done the right type of trial, or what it is they want to know? So if they want to say, is salbutamol great for acute severe asthma, it may not be very useful to use a cohort study from, or not say a retrospective cohort study looking at what was done in the past, because it doesn't really answer your question about whether it works now. So you think about what methods they've used and whether it matches the question they want to ask. Number 3 and number 4 are basically what I call the so what. And I'm sure everyone's been to meetings and seen papers published, and they come up with fantastic statistical significance, marginal, if any, clinical relevance. And at the end of it, you just go, well, so what? And I think it's a question that I used to really fear when I was doing any research, is at the end of it, you kind of think, oh, right, what's the point in all that? It hasn't made any difference to anything. It hasn't really answered any questions, not moved things forward. The classic one I give is pain scores, a new drug for pain. Pain scores are quite irritating because depending on how you analyze them, people tend to not analyze them correctly. And it's very easy, if you do a continuous analysis, to get a significant difference in pain scores. So you give a drug like a lidocaine infusion, and the post-op pain score goes from 8 to 7. And that would be almost certainly, depending on numbers and everything, statistically significant. But is it clinically relevant? And I would argue one person's 7 is the same as one person's 8, and one person's 8 is the same as one person's 7. And I argue dropping a pain score by 1 is probably not that clinically relevant. And within that, you can add in what the confidence intervals are and things like that. So I think it's quite a useful question, is when you've read a paper, at the end of it, just say to yourself, well, so what? What's this actually showing? And the final point is, are the results relevant to my patients? And this was asked a lot, particularly with the prone trial, where people were proned lots. And then when we went to the COVID pandemic, everyone started proning. But the trial was within, it was a really good trial. But prior to that, there had been a lot of trials on single center proning patients in teams that were really good at it and done it all the time. And one of the arguments prior to COVID against prone positioning was that, well, we don't do it all the time. We're not, this is at the Royal, for example, we're not a specialist respiratory center. Are we actually going to cause more harm by putting patients prone than good? So that's what it means by, are the results relevant to my patients, is what I found here. Do I have a similar cohort of patients that would benefit from this study? So I'm just going to go through these in a bit more detail. So yeah, what is the question? So if you read a paper, try and find the hypothesis. It should be in the title. It's not always. It should at least be in the introduction. And what is useful is also change that in your mind to a null hypothesis. I wish authors would actually just say what their null hypothesis is. And I also wish when they're doing statistics, they'd actually start with a line saying, this is a null hypothesis and this is how we tested it, rather than making you do it. But anyway, it is important and it is useful, but people may avoid doing it because it makes their study look better. Anyway, so does the study address a clearly focused question? Next thing, are the methods valid? And this is where it can get really, really complex, because a lot of authors seem to forget that science communication should be about clarity and about communication. And a lot of studies don't make the method very clear. So it's important, I think, if you don't really get what's happening, is write it out. Draw out a diagram, draw out how things link together, which group leads to which group, what numbers were in which group, and try not to criticize it as you're doing it. Just kind of say, all right, this is the method I use. Let me just be clear what they actually did. And then you can say at the end of that, well, that's just bonkers. Why do they do that? Or you can say, well, actually, no, that's actually quite elegant and quite nice, and they have justified it. But yeah, sorry, there's a bit here also about valid studies. So although double-blind, multi-centered controlled trials are the kind of be-all and end-all of research, they're not, in ICM, they're difficult, but I'll talk about that. But as they are the gold standard, doesn't mean other trials have no validity. Other trials do move science forward. They may not necessarily be as definitive, but they definitely are useful. And should, so even if it's a small trial, relatively small, it's not an RCT, but a small interventional trial, it can move science forward, and they're important things to look at. And I'll talk about this in a minute. It's not all about p-values. That's the thing that medicine's really biomedical science have really fallen down with. Oh, I'll talk about now. So statistics. So again, I haven't really got a huge amount of time to go on about statistics, but there's a talk I also give about how stats are generated and how you can look at them. But fundamentally, what you're asking, are the statistical tests they did in this study actually correct, or at least justified? So you may not know, you may not know it's correct statistics, but if they justify that, at least it gives you some confidence that the authors have written something sensible. There are, I mean, I'll come on to it in a minute about what sort of things you look at. The justification is important. What we all tend to do is tend to run down to find the p-value. And if the p-value is greater than 0.05, you tend to say, oh, well, that's a rubbish trial. It's not proven anything. Let's not read it anymore. That's arguably not justified. And in fact, what you should really probably focus on things like effect size and confidence intervals. And I'll talk a bit about P in a minute. But try not to skim a whole paper just because the p-value is not correct or not within our predetermined range. So talking about the stats a bit more, the classic mistake is mixing up the data that's in the paper. So data can be continuous, as in like seconds, height, that sort of thing. It can be ordinal, which can be or like EWS or pain scores, and it can be nominal or descriptive, which is actually labels. But the main thing is about the two questions you're asking about data is how are the data distributed? So do they follow particularly, well, continuous data really, but it can be ordinal as well. But how the data, do they follow a normal parametric distribution or do they follow non-parametric distribution? And are the data, are the sets you've got or the information you've got sampled appropriately? So have you taken enough to represent the population you're interested in, and are they relevant? And it sounds slightly esoteric, but there is clear relevance. So I think it's clopidogrel. The early studies of clopidogrel showed it was very good at in activating platelets, but it was done mainly on white Caucasian, mainly men, if I remember rightly, but it was certainly white Caucasians. And it turns out that actually it's probably about 20 or 30% less effective in patients of African descent, or Afro-Caribbean. So that's to do about sampling. So it's important that the patient, the data you're analyzing is from an appropriate sample. Certainly if you're going to conclude that this is effective, you can conclude this is effective in a certain population, that's fine. But yeah, and also the distribution of the data. And so if your data are, they themselves, you believe are parametric, but the population they come from is not, then you can't really say it's representative and you can't really do a parametric analysis on it. Anyway, it's probably a bit more. So anyway, the data stream is important because the reason it's important is because the tests you do are fundamentally divided between normal tests or parametric tests and non-parametric tests, and you can tell which they've used because one describes the mean and one describes the median. So where you see mean confidence intervals, that is parametric, and where you say median interquartile ranges, that's non-parametric. If you do the wrong test on the wrong data distribution, you get different results and may potentially inaccurate results, and you're more likely to get false positive and false negatives. So yeah, so the stats, what kind of data have they got, how are they distributed, how they analyzed well, which data points have they analyzed? Have they left ones out? Have they done the same analysis over and over again on the same set of data? That's something called p-hacking, where you just keep doing the same analysis over and over again. You just keep adding more and more patients in until you get a number you want. That's one of the reasons p-values are not to be trusted. And yeah, so you look at how they've been analysed and have they truly compared against null. The other thing is they don't always compare against, they declare a hypothesis but don't actually test it. Fundamentally, though, really the peer reviewers are supposed to do all this for you. So when your paper is published, this is why the impact factor or the reputation of a journal is really important. Because if it's a journal which does not have rigorous peer review, it's quite easy to read papers that are statistically flawed, made incorrect conclusions. So ideally, you want journals that are appropriately and properly peer reviewed, but by people who know what they're doing. I know the BGA does a lot of peer review, normally about 2 or 3 different people will peer review a paper, and there is a statistician who will analyze some of the if it needs analysis, you can look at it. Other journals might just use an editor. I think anesthesia may have changed, but they just use an editor who decides. A very experienced, very good editor, but it is one person. So anyway, so the peer review should do a lot of this for you. So you shouldn't, when you're reading paper, need to do it. But if you are a bit nerdy and like this sort of stuff, then knock yourself out. Right. Where am I next? So yeah, statistical mistakes that are seen over and over again and are in loads of papers and have made trust in published. And I'll come on the end about a bit more of this. Now, I could do a whole talk about p-values, which I think only I would find interesting. But if people do want to talk about p-values, I'm willing to give it. Fundamentally, we don't, in medicine, we're taught p incorrectly and we use it incorrectly. And there are lots of things about it. And p is actually a really non-intuitive concept. It really is a probability of it's a probability related to the null hypothesis, not the alternative hypothesis. So what you're saying is that null hypothesis is not true. And what it actually means is if you're, in an infinite world, or in a world where the value, the data are actually, the difference is actually true, you'd only see it 5% of the time, or as small or as or larger than than the difference you're seeing. But what that means is that you're testing the null. It doesn't necessarily follow if the null hypothesis is false. It doesn't tell you that the alternative hypothesis is whether it's a little bit true, very true, really true. It just tells you it's different. And it doesn't necessarily tell you which direction as well it's different. It could be that it's better, or it could be that the alternative, whatever it is you're measuring, is worse. And the other things to remember with looking at statistics is that the software or the people is just working with numbers and digits. It's us who say that's what these digits mean. And I sometimes find it quite useful just to think back, well, what you're saying is this group of numbers, and it's demonstrate significant, or rather, does this distribution of numbers compare or differently to this other distribution of numbers? It's nothing more than that. But we say, well, that means this drug is better, or we say that means Groening is brilliant, that sort of thing. And one of the weaknesses is that, a p-value of 0.001 does not mean it's not, it doesn't mean this whole concept of highly significant. It doesn't really mean how strong that effect is. It just means that there is a difference, and you can be very confident there's a difference. But there's no such thing as highly significant. It just says there's a difference or there's not. Yeah. Okay. There is an argument that you should look more at the effect side, or things like confidence intervals. One of the problems with science publishing is that you'll only ever see papers published where they have p-values less than 0.05. There's scientific bias, which means, they always say that the journal negative studies would be absolutely enormous, because a lot of studies will produce non-significant or no significant difference. But they're still valuable. They still provide valuable data. Sorry, the dogs are going mental. The other one is correlation to causation. Again, during COVID, we saw this a lot. It's very important when you're looking at data to make sure, particularly retrospective data, that they've not over associated something. So 100% of people that drink water die. There's no one who's ever drunk water who survived. That is a correlation, because everyone in their lifetime drinks water and everyone dies at some point. It's not that drinking water makes you die. It's just that you drink water and you die. And you see this a lot, and there's been attempts to try and change that. So things like logistic regression analysis is used in a lot of retrospective data, and what you're trying to do is isolate it from certain things, so you can actually improve your confidence in the causation. RCTs are designed to improve your confidence in causation by removing a lot of the variables, or making both groups as homogeneous as possible. Okay, and then small samples. In small samples, you can get a significant difference, but the sample is not relevant. Is a bad sample of your overall population. And also, if you do get a significant difference, it often tends to mean there's a very large effect. Whereas actually, if you did in a bigger population, the effect size would be much smaller. So yeah, less likely to reveal the true data distribution, and you're going to overestimate the true effect size. Okay. Hopefully, I mean, it should be. I mean, let's say there's quite a lot that can be said about this, and it is a big issue in science at the moment. So finally, yes. So the final, well, not final, third point, but also relevant to the fourth, is my so what question. So you've seen these studies, you've seen these results, you've read through them, they're really interesting, but what is the importance? What's the relevance of the data? Not only does it affect your practice, not only is the impact big or small, but their studies may have loads of limitations. It may have been done on, only one kind of person, or may have done it only on men, no women, or the imbalance between the sexes. How does it compare with other studies is also really important. If this is the first study to show a difference, what was wrong with all the other studies? Why didn't they? Or if this first study showed no difference, which is actually more common, what made this study special compared to the others? And are the conclusions justified? And again, authors have a tendency to overbelieve their results. They'll say things, this shows a clear importance of doing this. It shows a clear importance of improving my funding and giving me more money. Conclusions are often overstated. So it can be useful to be appropriately cynical when reading conclusions. Most conclusions should say, this suggests this. It's a probability that this is an important difference. But future studies along the lines of blah, 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 should improve or validate the work we've done. Rightio. And yeah, relevance to me. One thing I just want to bring up is we do read a lot of studies where you see benefit, but you don't necessarily see harm. And essentially, unless you powered your study to demonstrate harm, you may not see it. There's a thing called the rule of three, which is you basically need 3 times the number of patients in the trial to give you 90% confidence to detect an adverse event. So if you have 3,000 patients that get a drug, there's a 1 in 1,000 risk. So what's that? 3,000 divided by 3. Yeah, 1 in 3 divided by 3,000. There's a 1 in 1,000 risk of an adverse event. So if you want to detect a drug with harm with a risk event of 1 in 1,000, you would need to recruit 3,000 people. If you've only recruited 1,000 patients and virtually no one's had any adverse events, or no one has no adverse events, you can't say that there is no risk of adverse event. What you can say is that risk is less than 1 in 1,000, or probably 1 in less than 1,000. But there are a lot of drugs we use that have significant to that patient, clinically significant adverse events. Arrhythmias for vasopressors and inotropes are the big one. And a lot of studies don't always reveal the actual rate of those, and they aren't powered to rate those. There are some, but it's not something that's always noticeable. So it's always worth thinking about when you're reading papers, particularly around drugs and interventions. What are the adverse events? And again, with case series, laparoscopic work, when that started, and case reports, one surgeon is unlikely to operate on 300 or 400, 3,000 or 4,000 patients in a row, in a short enough period of time that you can't account for differences due to changes in care. So there may well be a significant risk. 1 in 1,000, we do tell patients will risk 1 in 1,000. And so you won't detect that. But it is important to look at these, to consider this. Right. So the final thing about reading a paper, it can be useful to read the references, partly because it's quite entertaining, because you'll read the references and you'll realize some of them don't exist. They're just completely made up. When I peer reviewed, this is what I found. Or it's linked to something completely irrelevant. They just added it in and either got it wrong or just put in something that just doesn't make sense to bulk it out. But references are good for, especially if you're doing a literature review, for getting the information that led to that paper. So there are lots of studies in intensive care medicine where the references will give you all the background information, and hopefully they reference a nice review article which sets the scene for everything. So they are useful. Don't just ignore them. Okay, so in Journal Club, you'll be asked to do these things. I will give you a link now to this. Well, I'll show you a link so you can download basically a worksheets to go through if you're asked to appraise a paper and you want to do it in a more formal manner. If you're asked to read a paper, I find the most useful thing is this: find out what other people have written about it. Because Journal Club, you're normally asked to present a landmark paper, and no landmark paper has ever been published which hasn't got about 2 or 3 people at least writing a commentary or review of it. And so if you're asked to present a paper at Journal Club that isn't overly obscure, then you will find other authors have commentated on it or have written an appraisal for you. So that's a way of saving time. And it doesn't stop you doing it yourself, but it is a way of saving time. But I probably shouldn't tell you that. But anyway, is what I do. But there are tools to help. So this is a link to Centre of Evidence-Based Medicine. You can either write it down, or I'm sure these slides will be online, or you can download them. But CBM, they have sheets that you can work through. You can go through systematic reviews, diagnostics. The RCT one's quite good. That's an example of what it looks like. And it makes you go through the questions, and it tells you how to work out things like relative risk and absolute risk reduction and that sort of thing. So that's quite useful. So if you ask to formally critically appraise a paper, that's a link you can use. Right. Final 2 slides. No, 3 slides. And final 2 or 3. Anyway, so talked a bit about types of trial. Talked a bit about how you critically appraise a paper. Just wanted to finish on some of the big problems that we have now and have become more and more relevant over the last decade or so. One of the problems is that in the pursuit of P values and in the pursuit of publication, it's getting very hard to actually read some papers because they will use very obscure language or very obscure tests which involve an awful lot of thought to try and figure out what it is has actually been tested and what they've done. And some, you do need there are statistical experts who can go outside the t-test and will know the various permutations who need to look at them. But it is getting hard for even those who do it for a living. Well, I don't really do it for a living, it's all free, but peer reviewers. But one of the big study issues is that a lot of studies, and it can be up to 50% of studies that are published, their data cannot be reproduced, which is really frightening. That you think some of these studies are published that's showing these significant effects. But when someone at some point somehow manages to get funding to reproduce the study, they can't get the same results. Either get negative or get a lower impact, which is a real big problem. So big a problem that our government has actually decided to look into it. And that's what the reproducibility of research inquiry is all about. And that's 2021. I've probably been distracted by other things since then. But it is looking into the issue that a lot of science that they fund, a lot of it's government funded, actually is useless or say unreproducible. There is a project. There's a couple of areas, psychology and cancer biology, are looking at, called the Reproducibility Project, and they found when they were able, they could only replicate about 45% of the studies, because a lot of the information they needed wasn't published or the authors refused to divulge it. But they found that in 85% of those studies, the effect size was smaller than initially published, which can have really big implications, certainly for things like cancer therapy. So yeah, and there are many reasons why reproducibility is an issue. One of the big ones is that no one wants to publish the study that's already been done. It's very hard to get funding for a study that someone else has already done, because PhDs are all about novel work. Funding bodies want to kind of change the world and want to show that their money has been put into something that's made a difference. But actually, there are a lot of studies that we really should just do again, and see if they have any changes and whether it's made any difference, and try and link into maybe changes of care. But anyway, something to think about. False research, and this is the other problem. So these are 4 famous people who have caused all sorts of issues, and I would argue, certainly in the case of Wakefield, responsible for the deaths of tens of thousands of people. So these are people who published research. A lot of it was utterly made up. Some of it should have been, like Wakefield stuff, should have been caught by a peer reviewer. I don't know why it wasn't. But the influence of some of these patients, some of these clinicians, has been, extraordinary. 2 of them are anaesthetists, Scott Rubin and Joachim Bolt. So even our amazingly ethical people like anaesthetists can fall foul of this. So there's a talk about ethics I can do one day if people want, but it talks about the impact of and how we can avoid the traps that these people fell into. A lot of it's about publishing, the need to publish. Some of it's about ego and some of it's about money. Isn't everything? So the final things, intensive care medicine. I think we're reaching the end. Good. So intensive care medicine. What about research intensive care medicine? So everything I've talked about, the gold standards and all that, unfortunately, it's not hugely helpful in intensive care medicine. The main problem is our population of patients don't just have one disease. In fact, there's almost no test for most of our patients to tell you what disease they have. And if they have the disease, they may well be presenting it in an abnormal way. So yeah, I mean, we do have patients with specific diseases. Certainly the Royal will see hematological diseases, see rheumatology diseases. But actually what we in intensive care medicine we're treating isn't the disease. What we're treating is the physiological response to disease. And our job really is glorified physiologists. We use drugs to stabilize patients, so specific targeted drugs can work. Unsurprisingly, this means any studies we do into our interventions often show no benefit. In fact, the best studies we have show reduction of harm, which is why I think ICU's entered from the give tons of fluid, Shoemaker, loads of oxygen, let's make everything super normal. It's kind of drifted back down to, and then it kind of went the other way, and now it's kind of gone to, we need to give the right amount. And a lot of what we do is about working out what the right amount of intervention is needed. Tidal volumes, don't give too much, don't give too little. Fluid volumes, don't give too much, don't give too little. It's what I call the Goldilocks approach. And that's probably where we are. And most of our improvements are done around packages of care. But yeah, we don't really treat anyone. We don't really give anyone any medication that makes them better. We just keep them alive so they can get better. A lot of time we don't really know what we're treating. Yes, we know there may be disease driving it, but we don't know why the body's behaving the way it is. Sepsis is the one. I mean, sepsis is, we'll never, ever get to the bottom of sepsis until we actually figure out what it is we're doing with it. It's not a disease, it's a syndrome. It doesn't have a diagnostic test. Until we've fixed some of the sepsis uncertainties, all the trials will always come up short. I don't know if anyone's ever watched True Detective Night Country, but Jodie Foster's always saying you've got to ask the right question. And I don't think in ICU we have or are able to at the moment ask the right questions. There are a lot of very, very bright people doing work in this area to try and improve this, and using things like Bayesian statistics and stuff to improve our trials. I think COVID actually was a really good, the REMAP CAP trial is really, really interesting, and actually shows what can be done if the right question is asked or the right questions asked. And one of the other thing is mortality. You know, we always use mortality as an outcome, but a lot of our patients don't. I think a lot of our patients don't die because of the disease per se. They die because of their comorbidities, which have been affected by the disease. And we palliate. You know, we say, look, this patient's run out of gas. You know, they run out of steam. We just need to stop what we're doing. Or it's not in that patient's best interest. So we maybe could get them alive. We maybe could keep them alive and get them through to a residential home, nursing home, get them through to a brain injury unit. But that's not always the right thing to do. So when you're doing research in ICM, there is a question whether actually we should be looking at mortality. Problem is, if we don't, no one pays for it. So anyway, that's yet another rant for another day. Right, I think I am done. Slight whistle stop tour, but anyway, I hope it was vaguely interesting. Does anyone have any questions, if anyone's still awake?
Thanks, Simon.
All right.
Very, very thorough as always.
It's not ranting, it's teaching.
I'd love to hear your hour-long session on the p-value.
No, you don't. You really don't. Really don't. It is interesting. I find it really interesting that they're just so rubbish. Yeah. But yeah, there are lots of issues about it, but it has made me lean much more towards thinking I need to learn more about Bayesian statistics, how to actually do it. But it's basically the whole thing is for frequentist statistics just don't. It's very, very counterintuitive, and what we want to know isn't what it tells us. It's a bit like sensitivity and specificity. You want to know, does this test work? And you need your positive predictive value. That's what you want, not your sensitivity. And it's like that with hypothesis testing. I don't want to know that the null hypothesis is wrong. I want to know that the alternative hypothesis is true, and this is the effect it has. Yeah. And our stats don't teach us that. Anyway, sorry, I almost start the talk now. There was a question about impact factor. What's the magic number of it? Oh, right. So good impact factor. So impact factor is a difficult one. As the answer to everything in medicine, it depends. I don't know if there's a magic number. I don't know the numbers, but if you are working in respiratory medicine, really big area, really big subject, lots of people citing articles, lots of people reading about asthma or diabetes, you want impact factors, I think around about 15 to 20. I think that's considered really strong. If you're looking at the Journal of Nasal Polyps, you will not find enough people reading or citing that paper to give it an impact factor above about 0.6. And it's a lot of it's to do with how broad the readership is, how willing people are to cite these articles. And the impact factor isn't by no means perfect. I can't remember the name of the scoring system because I'm not interested in it, but there are other scoring systems they use for is it Q-score for authors? I can't remember what it's called now. But I don't think there isn't a magic number. What you want to do is look at journals within your specialty and think about the ones with the biggest impact relative to your specialty. So I can't remember BGA and anesthesia. I used to know it, I've forgotten. But the BGA and anesthesia both have quite, for our specialty of ICM and anesthesia, have quite big impact factors. JIX has recently got one that's gone above 1. It might be 2 even. So JIX is improving. Critical care medicine is a big one, isn't it? So yeah, you basically need to look at it within your own specialty. The American journals do seem to have bigger impact factors, but then again, they've got a few million more people to read it, because you tend to be biased towards the country you train in. So to answer your question, it depends. I don't know. Would love to hear my talk about p-values. No, you don't. No one does. No, there is a talk. I'll do a talk about, at some point when I figure it out. I'll do a talk about Bayesian statistics and p-values. But it is interesting, and it will affect how we do research in the future.
Try getting your papers on infrared thermography cited. That's quite tricky.
I don't know why you got experience of that. Be one person in Uzbekistan.
Yeah.
You only put it there by accident. Have you one of the references that was put in by mistake? I mean, confocal microscopy in cells. This is exactly the same.
Yeah.
Okie dokie.
It sounds cooler than it is, and that's really a stretch. Cool. Thanks for that, Simon. That's really appreciated. That was a really good talk.
Pleasure. People can feel free to email me or contact me, or I didn't really say who I was, did I? Sorry. But yeah, I'm one of the intensive care consultants at the Royal. Feel free to email me or message me if you've got burning statistical questions, or even not burning ones. Okay. All right. Take care, everyone.
Did you think about having a YouTube channel?
Did I think about being a YouTube channel? No.
Yeah.
No.
Yeah, Fandom Flags, like Fandom Statistics.
I don't think A, anyone would watch it, and B, my goal in life is for no one to know who I am. I'm a classic intensive care anaesthetist. If no one knows who I am, that's brilliant.
Is that why you've got the fake beard and glasses?
Yeah. It's a fake nose as well.
Oh, thanks, Simon. Really
all right,
appreciate it.
everyone. Speak to you soon. Cheers. Bye now. Bye.
Hello everyone, my name is Mira. I'm one of the SD5s in anaesthetics, currently working at the Glenfield. And I am going to be talking about a paper that I read recently that I found interesting. Unfortunately, this is not a landmark study. It is probably a bit obscure, and embarrassingly, the presentation is quite low on statistics, but so it's a hard act to follow after Dr. Hart, unfortunately. What I will be talking about is the effects of mechanical versus bag valve ventilation on gas exchange during CPR in emergency department patients, a randomized controlled trial. So why did I choose that? Because I had some ECMO teaching recently, and we had some interesting discussions about whether we should be taking our ECMO patients off the ventilator when they go into cardiac arrest. In that specific patient population, it doesn't make a lot of sense unless, of course, the ECMO circuit goes down. And then I was listening to a podcast recently, and they again mentioned this bag valve ventilation versus keeping the patient on the ventilator, and I thought it might be worth sharing with everyone. So the Research Room is a monthly podcast that you can all listen to if you want on your long drives home. It is run by emergency physicians, but a lot of stuff is relevant to us anaesthetists and people that work in intensive care. So that's why the topic has come up. This is the paper, as I have said. It is a quite small study, but with a very specific questions, which I will talk about in a second. It is all, if you want to look it up, it's on the Journal of Resuscitation. That's where this is from. And if you sign up to the podcast, you can access it for free. So our current guidance by the European Council of Resuscitation is, of course, that if anybody has gone into cardiac arrest, you either do hand mask ventilation at a 30-2 rate of chest compressions versus breath, or even if you've got a supraglottic airway and you think there's a leak, again, you would do a 30-2 ratio of chest compressions versus breath. And you can change that to a desynchronous continuous CPR with 10 breaths per minute once you've got a well-sitting supraglottic airway or an endotracheal tube in. Why would we consider putting patients on the ventilator instead? For a multitude of reasons. Possibly if you're the only person available, which is quite rare, I think, in the UK. But what could more likely happen is that you might be the person leading the arrest, and you might want to have your brain free leading the arrest while you allow the ventilator to do some of your work. What happens often when you're trying to do multiple things at the same time is you are either hypo or hyperventilating your patients. Or in the unlikely situation where there's a mass casualty or there's loads of patients again, getting some more hands-free might be an option. The other advantage in very advanced ventilators these days is they have a CPR mode. So they're actually, you know, the barriers of leaving the patients on the ventilator, like high airway pressures or the ventilator continuously alarming, they might not be there anymore if the ventilator can work around higher airway pressures and variations in tidal volumes. And as I mentioned, there are some specific patients groups where it might be appropriate, like patients that are already on ECMO or patients that have prolonged cardiac arrest and need prolonged periods of CPR. Again, putting them on the ventilator might just give them a more consistent ventilation method. The downside is that often our ventilators are not very adaptable. They often will alarm at high airway pressures. They often cannot cope with the variation in tidal volumes. So that's something to be aware of. So this randomized control trial, to set the scene, this was done in Thailand, as you can see, end of 2021 to just about a year period. And this was done a little bit after COVID, and the clinicians in Thailand were told during COVID to put everybody that arrived in the emergency department that was intubated on the ventilator to reduce clinicians' exposure to COVID. So they did that for about a year and then went on to test whether that is an acceptable thing to do, essentially. So it's a prospective, non-blinded, randomized controlled trial they did. And they looked at adult cardiac arrest patients that arrived in the emergency department at that center. Think people that they excluded were trauma patients. They excluded patients that achieved ROSC prior to them being intubated, pediatric patients, pregnant patients, patients that either were suspected to have COVID or were known to have pneumothoraces were also excluded for obvious reasons. And if they thought that the patient has signs of irreversible damage, they too were excluded. And they excluded patients that were intubated in the pre-hospital settings, probably because in the pre-hospital settings, everybody was back valve ventilated, so there would be interference with the study. So I think they looked at 120 cardiac arrest patients in total. After the exclusion, they had about 60, and they did a one-to-one randomization to either group. If they were in the mechanical ventilation group, they got volume control ventilation at about 6 to 7 mils per kilogram with no PEEP. The respiratory rate was set at 10, and they received 100% oxygen. If they were in the manual bag valve mask ventilation, they had a bag of at least 1.5 liters, a 15 liters flow, and the operator was supposed to look and ensure that the patient had about a chest rise of 500 to 600 mils, which I personally think is a bit challenging, but that's what they were asked to do. And again, they were asked to ventilate the patient at a respiratory rate of about 10 breaths per minute. While that was happening, both groups of the patients received manual chest compressions. The primary outcome measure was a arterial blood gas that was taken anywhere between 4 to 10 minutes after commencing the ventilation technique. And because it was a small sample size, they powered it up to say that if there was a difference of at least 80 millimeters of mercury or 10 kilopascal of arterial oxygenation pressure, then that would mean there was a difference in the oxygenation between those two groups. And these are the results. As I said, they managed to include about 60 patients in total over the course of the year. A surprisingly long median intubation time, about 24 minutes. But I suppose if you consider that these are patients that could have arrested in the pre-hospital settings, by the time they get transported and arrive in the emergency department, it seems possible. And what they found was that the median partial pressure of oxygen was 36 millimeters of mercury in the hand bag ventilation and 29 millimeters of mercury in the mechanical ventilation. Confidence interval about 15 to about 70 millimeters of mercury in both groups. So not statistically different between those two groups. And they looked at other ABG parameters. They looked at acidosis. They looked at whether there was any difference in overall survival. And again, there was no difference between those two groups. So what they then concluded was that there was no difference and that therefore mechanical ventilation is something that is feasible and acceptable in terms of effectiveness for ventilation during CPR. So yeah, I thought it was really interesting. Before coming here, it had never really occurred to me to put somebody on the ventilator. Instinctively, when somebody arrests, even when they arrest in intensive care, when they're already on a ventilator, you're always tempted to take them off the ventilator and manually bag them. So I thought it's something worth considering. This study is probably quite small. I think it's from a single center. It's not blinded, and of course it's also from a very different country from ours, with possibly different healthcare settings and trainings to ours. But I still think it's something that's worth considering. Especially in patients, as I said, that are already on the ventilator. And if you're sure that the problem is not an airway problem, it might just free your headspace a bit if you're the person that's leading the arrest. Problems with this, I think there are quite a few issues with the study. As I said, single center, not blinded. Other things is they only took one blood gas and compared it between the two groups. It might be interesting to look at serial blood gases to see whether there was a difference between the two groups. If they were prolonged arrest, it would have been it would have been interesting to see what the actual tidal volumes that were achieved between the two groups. And again, maybe secondary outcomes, looking at kind of lung injury in the both groups to see whether there was any difference. So a larger trial, maybe possibly blinded, possibly in multiple centers, I think would be a bit more valid. But in the meanwhile, it's certainly something for us, I think, to think about. But if we encounter patients, whether we need to take them off the ventilator or whether we should maybe put them on the ventilator if we know that this cardiac arrest is going to go on for a prolonged period of time. So that's everything that I've had to say about this, really. Any questions or comments? Yes.
Were there any other things that happened in the study? Did they look at any adverse outcomes as compared between two groups?
No, they as far as I could see, they didn't look at that. The only other outcomes they looked at was survival rates, which was comparable, but they didn't look at any other secondary outcomes at all.
Okay, and if you just go back to the differences in the millimeters of mercury, what do you think about? I mean, are these arterial PaO2s in these patients?
Yes. So sorry, the confidence intervals is 15. It was 15 to 70 millimeters of mercury in one group and about 17 to 70 millimeters of mercury in the other group.
What does a PaO2 of 36 millimeters of mercury equate to?
I will convert that.
80 is 10. 80 millimeters is 10.
Yeah.
So it's quite low, isn't it?
What do you think about an arterial PaO2 of 4.5 in cardiac arrest?
It's actually quite low. That's a good point.
I mean, it's sort of mitochondrial level low.
Yes, yeah.
Low.
Yeah.
So yeah, it's interesting.
I didn't actually think about that. That's true. I think I got a bit confused because it was in millimeters of mercury. Yeah,
It's
that's a lot
essentially-
lower than
it's-
in our patients'
Yeah,
populations.
it'd
Yeah.
be interesting to see what they were what supplemental gas it was. Sounds like it was probably
Well, they did
Like
say that it
CO2.
was 100% oxygen.
instead of
So they either got 15 liters via the hand mask, mask, or they got FiO2 100%.
Quick question, and it wasn't the VBG, just.
No, so it was definitely an arterial gas that they had taken, supposedly.
And in the mechanical ventilation group, they have put the peak to 0. Is that right?
Yes, it was 0. But again, that's a good point. That shouldn't result in such low.
Is that a difference between have they taken an initial gas before they started ventilating and then a gas afterwards?
Again, I think that would have been really interesting if they had done that. They unfortunately didn't. They took a single ABG between 4 to 10 minutes to reach these results.
profoundly hard.
Yeah.
Yeah.
Survival levels.
Yeah,
Yeah.
the bar was 0. Interesting.
What, I'm just curious, I just want to find this papers. What's the?
There is there is a
event, isn't it?
it's the Journal of Resuscitation. I'll bring up the
Journal of Resuscitation.
Yeah. This is the title, the effects of, well, you can read the title. I think if you have Athens login, you might be able to
Yeah.
to
It's really interesting from that perspective.
Interesting what arterial VO2 is if you don't ventilate at all.
yeah.
Probably higher.
So now it makes you worried that the intubation might not have been in the right place and things. And this is not something I had considered at all. So apologies, everyone.
No.
Yeah.
I think it's a good paper to actually have a discussion on for many reasons. And one of them is actually looking at the numbers. That's what we were talking about before I went on the break. That
Yeah.
people publishing papers and there are obvious mistakes, and they're just going through the peer review
Yeah.
to the journals, Interesting.
Any other
What
comments
sort of
or
vents did
questions?
they use? Was it just like a sort of transport, like, because in the ED there, do they have?
That's again a good
Yeah.
point. They haven't really mentioned
Because an RED,
a-
an oxylot, with that.
all they've set as volume control. But I mean, I presume our Oxylog is also going to be difficult to use during a CPR because it often as well alarms with high
I think
pressures
that's
and
the other
things.
thing, yeah, it's
Um,
constantly alarming. And it's just such a distraction. And you can feel compliance, how would you interpret the volume curves and all that when you stick them on an end?
But I think the counter argument against manually bagging them is that often we hyperventilate them. And every time we bag them, there's an increase in intrathoracic pressure, there's reduced venous return to the heart. So we're often affecting circulation because if we are hyperventilating them.
Is that
while if you put them-
ventilation or high peak? Or?
Well, if we are manually doing that, bagging them, it's, we are often bagging them with quite high pressures on our Mapleton C circuit, isn't it? So I think with a ventilator, at least you would get a static respiratory rate. So again, which is why it would be interesting to see what volumes each group would have been delivered and what the
Yeah, how
effects
can you
are.
estimate? Well, if you
Yeah,
chest, you get
yeah.
500-600 beat.
Well, not really. I mean, you could say when you see chest rise, that's a tidal volume growth, and most people's tidal volumes fall within 460 mils, depending on your height. Like massive.
I suspect we are overventilating. I suspect when we are bagging them, we are trying to achieve much higher volumes because it's much easier to see.
But is
Yeah.
that okay for a few minutes?
Yeah,
It's difficult
exactly.
to tell when they're doing CPR what's actually going in, isn't it?
Yeah.
Especially if it's an IGL.
I like this sentence. Parameters and rates of blood and circulation. So
Big word, full 0.
yeah. I like the I found the study.
Okay.
I like the population group, 57 male, percent male, median age 62, 37% only received bystander CPR probably that's why it was so low. And 20
But I think
of
that's
them
similar to
had
the UK
initial
population,
shock
isn't it?
Interesting.
Yeah.
I think a bigger study would be worth doing on this topic.
If I'm in arrest, not an ICU, I quite like patients that means I have to stay there.
But in ICU, you end up doing loads of things at the
Yeah,
same time,
it's nice.
isn't it?
Probably quite naive F2 question. Why is your instinct in a patient that's already ventilated and they rest? Why is your instinct to take them off the ventilator and back?
Gives you an idea about compliance. Also ensures that you know the tube's in the right place. You know there's nothing blocking it. And I suppose we are just used to being able to ventilate them in the other arrest scenarios.
Any problem that might, the ventilator that might have caused it. So you can take the ventilator out of the equation.
One of the main reasons is the ventilators just alarm like mad because the way they work is either by pressure cycling or volume cycling. So the ventilator either detects pressure within the airway and then cycles back to expiration, or it delivers a set volume and then cycles back to expiration. The problem is if you've got someone doing CPR, the intrathoracic pressure when they're squeezing goes up. So if it tries to deliver a breath at the same time you do a compression, it just cycles straight back to expiration. And likewise for volume, if they're doing CPR, you never reach a target volume, so it just alarms continuously. That's one of the main reasons. Yeah. Which is why sometimes ventilators that are more simple are better. Which is why people like the ambulance service use Ventivacs. It's just a volume divider, so it is literally a box about that big. You plug it in with fresh gas supply, you dial up what the tidal volume is and what the minute volume is and how many breaths, and it just delivers it. And it doesn't care about pressure or cycling, it just gives it, which is why they're brilliant for that scenario. So if that's what they use, then that's right. And they don't alarm until you disconnect them, and then they make a really loud squeaky noise. But yeah, that they're probably better for that scenario, which is what the military uses as well.
It would be interesting to know what our ventilators here in this hospital, for example, are able to do and whether they have got the CPR mode.
I don't know, got a look.
I don't think so.
Oxylock. Never seen it.
Our Oxylocs don't,
I
definitely.
don't think so.
Maybe the new one.
The Dragon might work.
You're not going to have them.
No. Yeah. Cool. Thank you very much.
Thank you.
Thank you.
Cheers. Right, back to work.
Oh dear. It was interesting. You had this study had a massive funding. It's what interests me.
Massive funding.
Yeah, it was supported by Office of Panama